I would like to start by thanking the International Organization of Psychophysiology for inviting me to participate in this conference, and in particular Professor Giuseppe Chiarenza. My talk at this symposium, organized by RINED, the Pauletti Foundation's Research Institute, proposes some reflections on the data that emerged from our research on the quadrato motor training in the light of a neurophenomenological model for consciousness, the sphere model of consciousness, on which I have been working for many years. And it is a model in which different dimensions of the self and the dynamics of the shift between these dimensions are theorized, as we shall see shortly. I will present here some of the general issues related to the self in developmental disorders. Then some of the results of our research on quadrato motor training, mindful movement meditation. And I will propose a possible reading of these data within the conceptual grid offered by the sphere model of consciousness. This reading provides research perspectives on the experience of different dimensions of the self in developmental disorders and how these dimensions are implicated in the amelioration of these disorders. According to models of development of the self through stratification, as proposed by Damasio and colleagues, and Desity and Somerville in 2003, among others, the construction of the self is a multi-dimensional and evolving process that takes place from infancy and develops during the first years of life. This process involves physical, psychological, and social factors and enables the development of different types of consciousness at different levels. Desity and Somerville highlighted the cognitive dimension of self-development, involving shared representations of self and the other, eventually leading to self-other differentiation. Salem Shentaub was one of the first to study self-recognition in children with developmental disabilities, including intellectual disability. He described the reaction of mentally retarded children, as they called them at that time, in front of the mirror, and he observed differences in their behavior compared to typically developing children. The reactions reported are varied, ranging from an apparent lack of self-image recognition to complex affective manifestations, including preliminary interactions with the reflection or various stereotyped behaviors. However, the children's reactions in front of the mirror seem to be an extension of their habitual behavior, and the confrontation with their image does not trigger more specific reactions in these children, even in the most severe cases. The most alarming observation was the apparent absence of self-recognition, which calls into question a possible absence of recognition of the other, as well as disturbances of self-awareness. According to Hay and Jespersen, regarding the difficulties of subjects with developmental disorders and self-recognition, we should distinguish between minimal self, and narrative self. The distinction between the non-conceptual minimal self and the narrative self goes back to William James. In the case of the minimal self, proprioception, bodily sensory inputs are predominant, and self-reflexivity is low. In the case of the narrative self, there is reflexive content within which there are representations of the past and future, including mental representations of emotion as negative or positive. Berkovich, Johanna, and Glikson suggested in 2014 that experiences related to the narrative self are perceived as more distant from the body, more abstract, and related to the future and past. It is also necessary to point out that the narrative self depends on the minimal self, but not vice versa, which might point to a subsequent stratification of the narrative self. From a phenomenological point of view, a tacit, pre-reflective self-awareness that is present in every experience without reflection characterizes the minimal self. In contrast, the narrative self is a more or less coherent self that consists of a number of capacities, such as the assumption of a particular perspective and the self-other distinction. The minimal self is not an abstract concept, but involves the dimension of embodiment and has a short extension in time. Consequently, it can be hypothesized that the difficulties of self-recognition and differentiation from the other in individuals with developmental disorders are due to problems related to the minimal self and the structuring of the narrative self from this. It is therefore particularly interesting to see what effects are produced by motor paradigms involving body perception and movement. Considering, moreover, that it has been hypothesized that there is a connection between the pre-reflexive sense of self and the motor system, in which the cerebellum plays an important role. So let's see what the effects were on quadratomotor training's practitioners in subjects with developmental disorders. In general, we can say that the QMT, quadratomotor training practice, increased the synchronization of alpha power in the cerebellum in healthy and dyslexic adults. And the cerebellum is believed to act as a timing mechanism for sensory, motor, and cognitive processes. In terms of cognitive performance, we observed how these effects were accompanied by longer and more accurate time productions connected with increased attention. Better performance in reading. Findings have further shown that 1 month of daily QMT practice produces improved interhemispheric alpha connectivity and coherence in healthy adults. And the improved connectivity was accompanied by enhanced creativity, spatial cognition, attention, and improved reaction time. These effects might also be significant for the possible treatment of prodromal states of disorders such as Parkinson's and Alzheimer's, in which impairment in neurosynchronization and spatial cognition are usual. So what is QMT? Well, the quadratomotor training is a movement meditation paradigm with a very simple structure based on the sphere model of consciousness. QMT is designed to provide the practitioner's mind, even when subject to developmental disorders, with a dimension that is manageable from the motor, emotional, and cognitive points of view. In other words, to reduce the confusion produced by a multitude of stimuli that are difficult to manage. A condition of stress, in fact, increases the automatic reaction of fight or flight, preventing the production of a new response to stimuli. The QMT is based on a 50 centimeter by 50 centimeter square drawn on the floor. Quadrato in Italian means square, whose corners are numbered from 1 to 4, and the participant moves on them in response to a sequence of commands given by an external voice that invites them to move from one point to another. It is therefore an extremely simple figuration of the coordinates of space, the representation of which, according to Rizzolatti and Senigallia, underlies higher order cognitive processes. The assigned task is perceived as sufficiently simple, but not excessively so. The active waiting of the command, which cannot be known beforehand, is correlated with an increase in temporal production and attention span. According to this perspective, the QMT square is designed to represent metaphorically the space of the entire world of subjective experience, which is first and foremost the experience of a body in space. The reflexive perception of this bodily experience is what constitutes the dimension of the minimal self. The sphere model of consciousness is based on the same principle. Through a geometric spatial matrix, it places the subject at the center of the 6 directions of space. The back-forward coordinates represent the temporal unfolding. The left-right coordinates represent the polarities of emotion. And the vertical axis, with the high-low poles, represents the subject's capacity for self-determination, with the extremes characterized as intrinsic motivation and extrinsic motivation. The axis of self-determination or intentionality is the one least manifested in our functioning. The most common condition is that in which a certain experience of the past, interpreted through a subjective emotional condition, is projected into the future, producing the reiteration of cycles of experience. In this sense, we can speak of a circular and flat life, according to the graphic representation provided by the model. Only the insertion of the vertical axis, or in other words, an increase in intentionality, produces the shift from 2-dimensional to 3-dimensional experience. The center of the sphere is characterized in the model as the place of pre-existence, that is, a dimension of the self that precedes the experiences of autobiographical memory. Around this central core are concentrically arranged other internal spheres representing the different dimensions of the self, such as the minimal self and the narrative self, to which the dimensions of observing self and self-overcoming are added in the model. The hypothesis I want to propose is that the effects reported through the practice of QMT are mainly due to the action of the third axis of the model, namely self-determination. The manifestation of this axis favors a shift towards the center of the sphere, that is to say, towards the dimension of the minimal self, and even more, towards the center of the sphere, where the subject can live the present experience before the memories that condition their biographical path. Since QMT requires working memory, inhibitory control, and sustained attention divided between body and space, as well as sensory-motor interaction and predictive timing of movement, which all involve theta activity. We further measure, therefore, QMT-induced changes in theta. In fact, it has been seen how the QMT, like other movement paradigms, is able to modulate theta activity, connected to intentionality. This intentionality is expressed in 2 complementary capacities that we can call resisting and surrendering. The capacity of active waiting, required in the QMT, is maximally expressed when the command given does not indicate a shift from one corner to another of the square, such as 1, 2, but when the command is of the type 1, 1, In this case, the practitioner remains in place, resisting the automatism of the movement and at the same time remaining available to listen to the new incoming command. To sum up, we can suppose that the difficulties of self-recognition and self-other differentiation encountered by subjects with developmental disorders can be addressed by acting on the dimension of the minimal self. Since the minimal self dimension is directly related to bodily experience, conscious movement paradigms may be effective in improving self-perception. Within this framework, quadratomotor training is effective in increasing cerebellar alpha power in dyslexic and intrahemispheric and interhemispheric alpha coherence in healthy adults. Effects that are accompanied by improvements in cognitive performance in both individuals with developmental disorders and healthy participants. In addition, QMT is effective in modulating theta activity, which has been connected to intentionality. So, in the light of the sphere model of consciousness on which the QMT is based, we hypothesize that in the paradigm's design, the determining component for positive effects is the use of intentionality, or self-determination. This self-determination applied to the manageability parameters of the QMT allows the subject to enhance their self-awareness as an embodied self moving through space. Consequently, conscious movement paradigms that solicit the capacity for self-determination may be particularly useful in the treatment of developmental disorders. And this would seem to be true according to the research which we are currently conducting, also in the case of neurodegenerative disorders. Thank you.
Welcome to our symposium on motion and emotion in developmental disorders, a spherical perspective, spherical psychophysiological perspective. My name is Tal Dotan Ben Susan. I'm the director of the Research Institute for Neuroscience Education and Didactics of Fondazione Patrizio Paoletti. So the aim of our symposium is to enlarge the dialogue between neuroscientific findings related to neurodevelopmental disorders, together with a clinical and theoretical perspective, which emphasizes that in addition to the cognitive deficits in developmental disorders, there are also motor and emotional aspects which should be taken into consideration. We will combine both contemplative neuroscientific knowledge together with cognitive developmental psychology and embodied theories of cognition. Mentioning also the sphere model of consciousness by Patrizio Paoletti, which was recently considered the most advanced theory of consciousness. I will start with my presentation on timing emotion, developmental disorders in the view of the sphere model. So we will start with an example of dyslexia, taking into consideration the three vectors of bodily deficits, emotional deficits, and cognitive deficits. So the cognitive deficits of dyslexia are well known, related to fluent word recognition, poor spelling, poor decoding abilities and reading abilities. The emotional and motor deficits are less acknowledged, but they are prevalent. So from the emotional aspect, for example, lack of self-esteem, coping abilities, and the large number of depression reported in dyslexia. And from the motor aspect, we know that there are many deficits and many times they are combined. Let us take small example from an interview conducted with one of our participants who suffers from dyslexia. So he said, my balance is not so good naturally, so it may have improved following a certain training, which we will soon mention. There were times I got confused and it bothered me because I felt stupid. In the beginning, I was angry at myself. Now think passing life feeling stupid because you're clumsy or because you have some deficits. What we will see throughout the symposium also is different approaches to what causes what. Here we will focus more on the motor aspect and especially on the cerebellum, which is traditionally acknowledged in motor control and coordination, but it is increasingly being recognized also as an important factor for sensory regulation, also for emotional regulation and cognition, as it acts as a timing mechanisms for both sensory, cognitive, and emotional processes. So our first hypothesis was, if dyslexic participants suffer from a cerebellar deficit, which is in line with the cerebellar hypothesis of dyslexia, which leads to motor impairment affecting their reading skills, could a specifically structured motor practice improve their reading abilities? To this aim, we chose to focus on the quadratomotor training, which here, as you see, is a 50 by 50 centimeters square on the floor, in which the participant has to move according to a sequence which is not known to him in advance. It requires both coordination and weighting abilities. So a lot of executive functions. This study was conducted in Bar-Ilan University, in which we compared 8 dyslexic participants to 8 healthy, normal readers. And the participants both trained for 28 consecutive days in the quadratomotor training. And we measured their cerebellar alpha activity and alpha coherence before and after the training, in addition to a reading task. Here is the experimental design, which you can see. The reading task was a single word reading accuracy and fluency task, in which the participants had to read. The final score was the total of number of correct words read in 30 seconds. Here are different words in Hebrew. And this was the MEG. This is the only MEG in Israel. And we focused on alpha activity, as I said before. So in terms of the results, in terms of the reading, we see that both the control and the dyslexics significantly improved the reading ability in terms of correct number of words read following a month of the quadratomotor training. And this was accompanied by increased cerebellar activity in the dyslexic group. So these are very novel findings in terms of the cerebellar involvement in dyslexia, and they are in line with the cerebellar hypothesis of dyslexia. We see that, in fact, the baseline alpha activity was lower in the dyslexic compared to the control group, and following 4 weeks of training, the cerebellar alpha activity increased in the dyslexics, and this was accompanied by improved reading in both groups. Now we can enlarge the model and see, until now we spoke about the oscillatory activity leading to improved reading, which could be considered the fast track. But there is also another track which starts with molecular change, which can lead to anatomical changes, also leading to improved cognitive abilities. And we will look at this in the context of additional learning and neurodevelopmental disorders. So neurotrophins play a vital role in this molecular path, and they enhance and allow neuroplasticity. We know that, for example, nerve growth factor and BDNF are two of the most important factors leading to training-induced neuroplasticity. Before showing results in impaired population, let's start with the pilot in healthy adults. And we see again that following 3 months of training, BDNF level can increase also in healthy adults. Here we see the level of pro-BDNF before the training and after 3 months, and they increased in all 3 participants. So this was the first pilot study, and in relation to the cerebellum, we see that this increase in pro-BDNF was in fact related to increased cerebellar volume. Then in recent years, we conducted several case studies. The first one that I'm going to show is of a 20-year-old dyslexic adult, which suffers also from, in addition to developmental dyslexia, also from dysgraphia, and has had very severe symptoms. So we see that we see the severity, and in fact, we see that following 4 weeks of training weren't enough for him to improve his reading abilities, but after 10 weeks of training, he in fact improved his reading, and this was related to also increased BDNF secretion. We see in these results the importance of embodied cognition and of specifically structured sensory motor training, such as the quadratomotor training, that support the importance of the cerebellum in skilled reading, and they begin to unravel the mechanisms that mediate cerebellar contribution to cognitive and neuronal improvement. Now, we know that the cerebellum on the one side could be considered as an oscillator, and in fact, we showed results related to this, which were related to improved reading, but in parallel, the cerebellum is also related to timing. And now I will show some of the results related to timing abilities and the quadrato. So the cerebellum is involved both in coordination and timing. And one of the timing paradigms, which I will show, is called the time production task. And in addition to this, we know that the cerebellum deficits are not only in dyslexia, but also in autism spectrum disorder and, for example, in Asperger. And the severity of the symptomology is related to the severity of the cerebellar deficits. One of the case studies that I'm going to show is specifically related to Asperger, which is in addition related to impaired social abilities. Remember that the cerebellum is also related to timing, right? So timing is in the base both of cognitive, but also of social function in order to know when to approach, how to approach, when to speak, when to respond, and so on. And our hypothesis was that, okay, we know that autism is related to cerebellar deficits, and we know that the quadrato can enhance cerebellar oscillations in learning disabilities. So could the quadrato lead to positive outcomes, and could this be related to cerebellar functions? I will show a case study of a 9-year-old boy who suffers from Asperger, who we trained for 2 months, focusing on the time production task. just to mention the time production task. So we see that in terms of the time production task, it's significantly improved following 2 months of training, in which the participant became slower and more accurate in terms of his time production. And this again supports the linkage between the cerebellum coordination and time productions. There are more results, but I'm going to skip them. And we go directly towards the sum. So I would like to say that following the Quadrato, we see in general increased alpha activity, both in terms of alpha coherence in healthy adults and in terms of cerebellar alpha activity in dyslexics. We know that alpha activity in general is related to improved cognitive performance and to higher states of consciousness. And we see that the Quadrato, as a specifically structured sensory motor training, can increase cognition in terms of reading, creativity, and spatial cognition. And this supports the embodied theories of consciousness. And we can start to suggest that the Quadrato motor training in parallel to other movement meditation can induce the transition from the narrative memory-based there and then self to the more embodied here and now self, which is accompanied by alpha activity. So future studies should examine this and the importance of bodily awareness, divided attention, and also the emotional aspects as possible mediators and modulators that could represent the link between mindful movement, both in healthy development and in developmental disorders. I would like to thank our collaborating institutes and partners and all our collaborators, as science is a team sport. Thank you very much for everyone and for the organizers of this great conference. Be well. Thank you.
Hi, my name is Karen, and I'm a neuroscientist and a psychotherapist. And my talk will try to add something more clinical to the topic of how we examine and deal with learning disabilities, most specifically dyslexia. So the main goal of the talk, I think, would be to try to convince you that we have to move from the question of what is wrong with you to the question of what happened to you. So more from the medical way of looking at things, like what are the symptoms and what is the problem, to actually a more humanistic approach of how you interact with life. And this is actually very much increasing in the field of chronic pain, following the work of Dr. Sarno and his followers already in the 90s. And in this case, you would ask, so what happened to you in your life when the pain started? And I think this connection between what are we complaining about, or the way we express difficulties and the difficulties we go through, is really important when we deal with disabilities and learning disabilities and neurodevelopmental issues. I didn't come up with this. In the 90s already, there was this huge study based on 17,000 adults that were asked about their childhood. And it basically, put on the first, in the front, what we call adverse childhood experiences, in the way, they're very prevalent in the society, the way it creates toxic stress and actually affect brain development, and the way it's linked to chronic health problems, mental illnesses, cognitive deficits, and complaints and substance abuse. But also, I think it's really important to see that it's kind of a loop, you know, so you go from generational embodiment historical trauma that creates a social condition to adverse childhood experiences that disrupt neurodevelopment, that leads to social, emotional, cognitive impairment, and to diseases and risky behavior and social problems and early death, or just like perpetuating this kind of context. So it is really important to put everything in a certain line of relationship. Things are not, you know, just, you know, one object in space. So when we talk about disrupted neurodevelopment or neurodevelopmental problems, it has to be put into the context. Following this study, a lot of organizations, whether it's NGOs or all sorts of public organizations, try to promote this knowledge and to bring it to educators and health practitioners and mental health practitioners. And basically, they talked about three types of ACEs: abuse, neglect, and household dysfunctions. When one of the parents has mental illness or in prison. They also mentioned that 64% have at least one ACE. This is based on the study from the 90s. And that the more ACEs you have, the more negative health outcomes you would have. So some of them can be related to behavior and the way we can hold to work, or, you know, be active and not consume too much drugs. And some of it is really related to mental illnesses, to sexual transmitted diseases, cancer, etc. Following this really huge study, there is a tendency to do more and more studies with big samples. And this is one from Philadelphia, about 10,000 children and youth. So it's not like it is retrospective in a way, but it's not just retrospective. And basically, they were collecting psychopathology information, but also cognitive functioning. And what we see here is the way, obviously, this here they call it TSE, so traumatic stress event, is actually dose response, has a dose response pattern in several psychopathology and in functioning and cognitive efficiency. So it's not just the classic stress-related disorders. And what we see here is what's interesting, besides the fact that it's obviously increasing with the amount of TSEs we experience, is that what you see is like when you only had one TSE, this is about 2,000 children, mean age about 15. They're just at the average, okay? So they don't have this, you know, a bit more capacity to succeed, to excel, to manage life. And they already have a certain small deficit that is growing afterward with more TSEs, but small deficit in social cognition. So you have to keep it in mind that even someone that is look like he's hanging on there, everything is fine, you know, basically it doesn't have too much resources to handle difficulties and challenges. Here another story published in 21. Here they present complex and non-complex trauma. Complex trauma is actually repetitive traumatic events along development. And what you see here is not just the obvious effect it has on cognition as tested by the Cantab, but it's also the important decrease in intelligence. This is also, and by the way, this is something we know from clinical work when we use, for example, neurofeedback, and we manage to correct the level of arousal in the system even many years later, then we see an increase in intelligence and in cognitive capacities. So it's just like a way of the brain, or the survival of the brain is kind of created this arrested development. What we see here is actually another huge sample published in 2017 on 76,000 children aged 4 to 17. Only 9% of them have ADHD, but what is really clear is that those who have ADHD have much more ACEs and much more prevalence of ACEs. And you have to keep in mind that a lot of these post-traumatic or traumatic symptoms that we see are also symptoms that we see in ADHD, like over-arousal, impulsivity, difficult to inhibit, difficult to attend something, and things are not always what they seem. And this is why the question, what happened to you, is really important. So don't stop just with the cognitive symptoms. The effects of developmental trauma is actually important because it alters the way some brain regions develop, and it focuses on survival. So how they facilitate survival. So we know that in trauma, we have overactivated amygdala, but we also know, and this is from the 90s, I think started with Ledoux, that there are two pathways to activate the amygdala. So one is more subcortical pathway, and one is more cortical pathway going to the sensory cortex to the prefrontal cortex. And then it's a pathway that is much more conscious, and we can maybe make a decision about. But what happening in developmental trauma is that the subcortical pathway becomes the dominant one. And therefore, we are instinctively, almost automatically, responding to threat. And it's non-conscious, it's not very much processed, there isn't very much information. It just again and again and again activating the autonomous nervous system, cortisol level. And this is, of course, creating chronic stress and a lot of health issues. But something more important, I think, even than realizing that the dominance is the subcortical pathway, is that the fact is that the brain, prioritize this subcortical pathway. So we do see damages related to trauma in cortex and in the integrity of white matter tracts. And this is, some suggest that it might be related to the way the brain actually tries to attenuate the experience and kind of attenuate the conscious perception of what happened to us. But it's also about protecting their survival mode. Okay, so this is a very smart move for the brain, but this means that we pay the price. So this survival mode actually makes us be more vulnerable cognitively. And when we think about it, not just in terms of the fact that our cognition actually is affected by trauma, but and this interacts obviously with our dispositions, so whether it's genetic or environmental or personality-wise, but it's also very much important to realize when the trauma happened, because the brain is not just, one state, like all brain parts develop the same way. So the stage of development is really important for us to understand the consequences. What we see here is, for example, that different brain regions have sensitive periods of development. So, for example, we know from studies with humans that when the gray matter volume of the right amygdala is damaged by trauma is around the age of 11, while the hippocampal volume is actually affected in earlier ages, around 3 to 5. Okay, while the prefrontal cortex is more affected in adolescence. So this is really important for us to understand the inconsistencies that we often find in the literature, but also in the clinic. That is that obviously not everyone responds the same way to trauma, but more than that, it depends not only what happened, because we saw that it affects differently the brain, whether it's like verbal abuse, sexual abuse, but when it happened, because then it interacted with natural processes of development of the brain. So if we kind of summarize what are the trauma symptoms we see, so we see persistent fear response, hyperarousal, increase internalizing symptoms, which is more about depression and anxiety, guilt, shame, diminished executive function, which makes it very hard to manage life, delayed development milestones, complicated social interactions. And I think you have to keep in mind that the brain anyway develop bottom up. Okay, so especially in childhood, yeah, so it goes bottom up anyway. But when we are in survival mode, then the bottom part is very much accentuated and prioritized by the brain, and therefore the up level of development is very much touched. And we know that from a lot of different findings, neurobiological findings that can help us understand some of the symptoms we see, like excess neural excitability, e.g. abnormalities, symptoms of temporal lobe epilepsy, diminished development of the left hemisphere, reduced size of the corpus callosum, attenuated activity in the cerebellar vermis, sorry. So what happened here is basically, if we look at even half of these symptoms, and we know something about language development and about findings in dyslexia, we understand how it can interact with what we see as dyslexic. And dyslexia is actually affecting almost 10% of school children. It's heterogeneous, doesn't seem to have one core deficits, the cerebellum, laterality, the thalamus, adaptation. You know, there are many different findings and model proposed along the years, but there isn't one model that explained the phenomenon, especially that it's a very complex process to read. It's mainly thought to be a processing disorder, and it's very much related lately to the stress-related genes and dysregulation of the HPA stress axis. But I think what's important is to understand the relationship with this kind of phenomenon that we see after in childhood trauma to this kind of disabilities. It can be this, it can be ADHD, it can be both, but we have to figure out, and not to figure out, but to be conscious that at least some of the children that we see with dyslexia are not necessarily dyslexic. They maybe also have reading disability, but it might be actually standing on something else underneath. The brainstem that we often talked about in terms of like the survival mode is actually very much involved in language, in coding acoustic sounds and speech and auditory signals and the timing of it. And it's also related to the degree of laterality in the cortical auditory processing. So we have to understand that when these brain regions are actually activated and engaged in survival mode, the cortex doesn't influence them too much and they take over the brain. And this is obviously affecting also all sorts of cognitive development, such as reading. What to do then? What I suggest is actually a more comprehensive intake, and you can profile, kids, like their safety and physiological profile. This you can learn a lot from the polyvagal theory, sensory profile, movement and embodiment, also using it in order to see how it helps mobilize the system and ground the system, dealing with stress, so a lot of work on regulation. Neurofeedback can decrease over-arousal that we often see. EMDR can desensitize trauma and help processing without too much involving content, emotional or cognitive content. So what we really want to do is help the brain process in order to create space for cognitive and emotional development. So the main message is going from sick care to well care. So from what's wrong with you to what happened to you. And we would like to see how we build up a community that actually think broader and involve much more than just the DSM diagnosis and some medication or one type of therapy. So thank you for listening. We'll meet on the panel, and I hope it gave you something else and something new to think about in relationship to learning disabilities. So thank you.
Hello, good morning, or good afternoon, or good evening, depending on the latitude you are. I first want to thank the excellent organization of the Congress to give us all the possibility to share knowledge and that will enlighten our future researches and clinical awareness. A special thanks to Professor Chiarenza, who took part of the organization, and to Talba Labandotan that organized this symposium. I will give you some cues to help us feel closer, even if we are spread all over the world. I'm Lia Telone. I'm a medical doctor in neurological rehabilitation and children neuropsychiatry. I come from Italy, and I prepared this talk during my holiday in Valtellina, a beautiful valley in the north of Italy, close to the border with Switzerland. 10 years ago, I founded a rehabilitation center with the goal of offering, with a large variety of different therapeutic proposals, instruments to children with neurodevelopmental difficulties and adults after neurological injury to improve their participation to life. In our big rehabilitation team, we strongly believe that the ultimate goal of bettering the motorial, cognitive, and affective functioning of people that come to ask for help is to increase their participation to life and consequently their self-confidence and daily satisfaction. Our foundation is named Elice, that literally in Italian means promote to manifest. I'm actually the president of this foundation that has one rehabilitation center in Milan with 30 members of the rehabilitation team with medical doctors, psychotherapists, psychologists, neuropsychologists, speech therapists, music and art therapists, postural therapists, physiotherapists, meditation and Tai Chi trainer. One in Parma, where you must know the Parmesan cheese come from, with 10 members of the rehabilitation team, and one opening this autumn in Crema. We were born to provide a clinical answer to many needs and not as a research center, but as we developed a curiosity in neuroscience possible contribution to clinic. And so in 2020, our research institute was opened with the goal of offering to other research institutes our data on patient diagnosed and treated with neurodevelopmental disease, and also to collaborate to the comprehension of the complex world of human development, human change, and human learning. Learning is one of the most fascinating issues for me, and the comprehension of all the mechanisms involved in this process attracted my curiosity since I was a child in school, and was asking myself why for some of my school friends was so difficult to remember a history lesson, and why for some others was so easy, and why for some math was a nightmare, and why for some others was so funny. In these past 10 years of work with the rehabilitation team of the foundation, we developed a model trying to respect the complexity of the rehabilitation process that is, I would say, similar to development, where genetic, environment, structures, motivation, memories, and many other factors are involved. So the UC model was born. That is how we deal every day with patients and one of the subjects of our researches. I will briefly explain it to you. I stands for interdisciplinary. That means that to better understand the complex nature of human learning and development, many eyes and many different looks are necessary. So, every one of the team with a specialization on the physical, motorial, or postural, or psychological, or motivational, affective, or cognitive aspect participate to put his observation together with the other to create O, that stands for holistic, that in Italian is without the H, vision, where the patient is seen as a whole, with his trouble and his resilience potential, with his difficulties and his abilities, and where each area is influencing another area. That is how we look at the development. More than the whole of the individual, we need to enlarge our vision to the systems to which the person takes part. Primarily his family, his scholastic or job environment, his sport environment, his social opportunities, his values refinements. As much as we observe systems, as much as we notice how there is a big variety of events and situations that influence one's personal development, learning or rehabilitation path. Our goal is to take care of all the influences we are able to register, so to create possible adjustment to the path or to understand some deviation from our expectation that might occur. The last word of our approach is the I, that stands for integration. As I told you before, our main goal is participation. That can be said also as integration of the different part of the person and in the diverse systems of the living experience. Let's now go deep in our daily approach. Our focus is development and the process of acquiring competencies. This process is extremely intense and fast in the first 3 years of life, with the huge acquisition of standing position, walking, eating and talking, and using our hands to keep a knife, a fork and the pencil to draw, and regulating our digestive and urinary system. Is still a big part of our daily experience between 3 and 10 years old, where we learn to play following rules, to tell a story, to share something is not present at the moment, to count and share objects, and lately to read, to write, to invent a story, to become friends. Our way of looking at the development process is based on the well-known dynamic system theory, where development is seen as a mountain stream, as you can see in this video, one from the beautiful area in Italy right now. A stream is moving all time in continuous flow and continuous change. Development is continuous. Whatever has happened in the past influences what happened in the future. The stream has also patterns. We can see whirlpools, eddies and waterfalls, places where water is moving rapidly and places where it's still. Like the stream, development has recognizable patterns, milestone and plateau at which behavior is quite predictable. The patterns reflect not just the immediate condition of the stream, however, they also reflect the history of the whole system, including the snowfall of the mountain last winter, the condition of the mountain last summer. The stream also carves the rock and the soil and creates its own environment, which then constrains and directs the water. The child's behavior in turn sculpts his and her environment, creating new opportunities and constraints. Depending on the condition of the stream, similar action may have very different results. Development patterns are also show this kind of non-linearity. It is difficult, maybe impossible sometimes, to predict the outcome of the process for any child in any particular situation. Sometimes chance events have large consequences, at other times they have little impact. Of course, if we want to analyze a particular aspect, we have to select a specific issue from the complexity of the reality, not forgetting all the other components, but letting them down for a while. So in these continuously influensive components of children development, we want to address the relevance of the motorial development and acquisition and skills on the development of the affective, social, and cognitive level. Evidence for this type of interaction can be seen in the finding that babies who have not yet learned to sit independently and those who have mastered the skill are comparable on measures of face processing, while those who are novice sitters perform worse, indicative of a reorganization taking place within the face processing systems. Another study finds that a baby who is given more opportunities to actively engage with objects shows an increase in orienting to faces relatively to a baby given only passive experience with non-social objects. Furthermore, crawling and walking in infants leads to change in social interaction from parents. This situation is extremely evident in little kids because the difference between being able or not to walk is so immediate seen. We theorize that also for a scholar-aged children, his postural stability, his equilibrium, his ability to simply manage his body, his ability to manipulate objects in their specific function increases the number of situations he is confident to handle and so influence how he emotionally feels. More than this, we theorize that his social behavior can be affected by a higher level of abstraction of the motorial development that helps him to understand the meaning of other people's postures and movements, and helps him and her decide how close or how far is the right distance for a satisfactory interaction with another person. Another component that we consider strategic within a physiological, affective, social, and cognitive development is the development of the executive system and all the sets of the ability of planification, inhibition of interference, good working memory, ability to maintain in memory elements to take a decision. So, we can draw this possible model to put together all the elements we spoke about, where the motorial part is seen as a basis that interact through the development of executive function to better develop emotional and cognitive and then social interaction. There are some contributions of scientific literature of the past 20 years that are consistent with this hypothesis, a theory that sustains the link between the different domains and theorizes that we can speak about proper specific learning disorder because the different domains are involved one within each other. Multiple contribution about the comprehension of the cerebellum in more sophisticated function as emotional and social that build from an abstraction of the elaboration of motorial ability and perception. Then work about salience network connectivity in children with nonverbal learning disorder showed reduced connectivity within the salience network relative to children with autistic spectrum disorder and typical development children, specifically between left and right anterior insula and anterior singular cortex, as well as between left anterior insula and right prefrontal cortex. Reduced connectivity from left to right was associated with greater social problems, suggesting that this pattern of altered function connectivity may underlie the social difficulties detected. Then we have crucial contribute that executive function plays in acquiring new learning, and we have the demonstration of changes in ability to read following motor training like quadratomotor training that is linked to changes in cerebellar activity. So now we have our contribution to presented hypotheses and findings. First of all, we approach the collection of the data. We observe 100 aged school children. These are the description of the age of the children. that came to our service declaring trouble in learning process. Each child came from a first session of 2 hours and a half where a detailed anamnesis of the kid and the family history is taken. Then there is a complete neuropsychiatric medical evaluation with observation of the motorial and coordination development, affective, emotional and social behavior and cognitive style. After these 3 or 4 more sessions during which formal tests are administered about IQ, learning abilities and many neuropsychological domains such as executive function, visual spatial abilities, language skill and also 2 projective tests, the draw of the human figure and the family, to collect some more information on emotional affective level. First, I'm showing you the distribution of the diagnosis. As you can see, there's not a big prevalence of one on the other. We found 8% with no specific disorder, 10% with dysgraphia, and 20% with dyslexia, where mainly at least another learning weakness was present, and around 30% for nonverbal disorder and mixed learning disorder. What we observe in our population is that many disorders were common to different patterns and not specific for one of them. Reading difficulties, for example, can be found in dyslexia, mixed learning disorder, any percentage also on non-verbal learning disorder. We can say the same for dysgraphia. Here on the right side, you can find the percentage of gifted children that we found in this population that came for school difficulty is the 16%. That's quite considerable. Then I'm showing you the amount of related difficulties that we found in this population. 70% of children showed some kind of emotional trouble. 70% showed fine motor skill impairment, more than 50% some kind of attentional executive disorder, and 30% visual spatial impairment and social difficulties. I would say it's quite a relevant amount of the population. The last observation is about the amount of related difficulties for each child with a diagnosis of specific learning disorder. And so you can see that there are 22 kids at 22% with 1 associated difficulty, 33 with 2, 20 children with 3 associated difficulties, and then with 4, 5, and 6. Also, these findings made us make a reflection on the possibility of a strong correlation between developmental domains and the distribution of difficulties that does not address to independent domains. So our conclusion is we found no specificity in neurodevelopmental learning disorder. The patterns of the difficulties were mixed. The majority of the kids, more than 75%, had 2 or more associated difficulties, emotional in the 70%, social, motorial, visuospatial, and attentional. And we noticed that motorial and emotional difficulties are the most diffuse and seem to have a link. Attentional is the second more common, and visuospatial and social are in the 30% of the kids and seems linked. So, from these findings, we dare to propose some key recommendations and takeaway messages. For clinic, to understand a neurodevelopmental disorder is crucial to take into consideration both in the diagnostic and therapeutic phase all the components of the child and how the different areas influence each other. It is important to be able to offer treatments that are designed on each child and address different components. It is not always useful to train reading in a reading disorder. It might be efficient to train tennis table to develop ability in hand and eye coordination. Maybe it's not always useful to speak with a psychologist in an emotional disorder. But it could also be effective in mountain bike training to develop better motor skill and self-confidence. For researchers, as we enlighten a multiplicity of difficulties that are present in kids that are usually considered with a specific disorder, now non-spreading other domains, we will have to make many more observations that help us to find clearly how domains are linked with each other and what kind of training could be really more effective because they address the crucial domains. And for parents, that might be many of us are, As we underline the big amount of motorial, emotional, and attentive fatigue in our sample, we can recommend to all parents and educators to facilitate as much as possible in the first 7 years of a children plenty of physical experiences that can let him and her proper develop his abilities, both with the whole body, with his hands in particular, and in the combined use of hands and eyes during movement. Feel confident in his body, and his movement will help him to be ready to deal with emotional development. Both these domains shows to be positively influenced from a well-developed executive system. This condition could help the children when he meets the challenge of school to have better instruments to develop learning and social skills. And thank you from me and for all the kids you are helping with your researches.
My speech today presents the results of my research on the temporal organization of dyslexic subjects in the time and the frequency domain. Relationship between dyslexia and the motor organization has been suggested in terms of theoretical and empirical grounds. Minor motor neurological signs as dysrhythmia have been reported in dyslexic children. These motor impairments have been related to the disturbance in time organization. To study the temporal organization in the time domain, we proposed a particularly difficult task that required the subjects to learn and reproduce a teeny time interval between 40–60 milliseconds by performing two self-paced ballistic movements. The task consisted in starting the sweep of the oscilloscope trace with the left thumb press and stopping it in a predetermined area of the oscilloscope by pushing the other button with the right thumb. The sweep velocity was 1 millimeter per millisecond, and the target area corresponded to a time interval between 40 and 60 milliseconds. Performance in this area were defined target performance. It is clear that this task, to be executed properly, requires a precise coordination of the two ballistic movements that can only be realized with advanced programming of the two movements. Learning a correct timing leads to an improvement of performance, thanks also to the feedback about the result obtained, which is provided in real time and which can be used to correct performances that do not fall within the target area. Dyslexic subjects have a lower percentage of performance in the target area and are much slower than normal subjects with the performance exceeding 100 milliseconds. They were also less accurate with the percentage of near target area performance lower than normal subjects. Based on the spatial temporal characteristic of these potentials and their relationship to electromyographic activity and performance, it has been proposed that there are 4 successive time periods during the skilled task. 2 are present during covert behavior, the premotor period and the postmotor period. For the purpose of this presentation, I will concentrate on the premotor period that precedes the EMG activities, and is characterized by the Bareil shaft potential. Its amplitude is higher during skilled and goal-directed tasks than during unskilled and not purposive ones. Its scalp distribution is prevalent in the central and the precentral areas. During unimanual action, the BP is predominantly on the contralateral hemisphere, while during a bimanual skilled action, it's symmetric in the right-hand subject, but not in the left-hand subject. This potential seems to reflect the strategic organization of the idiokinetic elements necessary to achieve the goal. In dyslexic subjects, the BP was reduced in amplitude, and its onset was just a few hundreds of milliseconds before the movement. We advanced the hypothesis that one reason of the poor performance was the defective programming and timing the two movements. On the left, it is shown the regional activation for timing identified from fMRI studies. Top panel shows cortical activation in the left and the right hemisphere. Bottom panel shows the cingulate as well as subcortical activation in the right and the left hemisphere. On the right, the diagram outlines the cerebellar and the corticothalamus-striatal timing networks and the intricate connectivity between these two regions. Many studies have clarified the contribution of the cerebellum in the organization of movement. It has been widely accepted that the motor cortices and the basal ganglia are involved in the generation of self-initiated movements. The cerebellum is involved in the timing of volitional movements. Other studies have also suggested that the cerebellum measures a single time interval, while the basal ganglia process rhythmic timing. Recent studies using the self-timing task have shown that the time course of preparatory activity differs between neurons recorded from the cerebellar dentate nucleus and the striatal caudate nucleus. Neurons in the cerebellum start their activity about half a second before self-initiated movements. It's more likely these neural networks work in conjunction across both sub and the suprasecond time scale as a unified entity. In this network, the cerebellar system is principally involved in initiation and adjustment during the acquisition of tasks, while the striatothalamo-cortical network is more involved in determination of timing. At the microscopic level, the cerebellar granular layer appears especially well suited for timing operations required to confer millisecond precision for cerebellar computation. This precision is believed to occur at the Purkinje cells, where parallel fibers and climbing fibers both synapse. This clock appears to be dysregulated in dyslexic children, which Linus has called neural dyschronia, that lead to inefficient integration of information from various brain areas. Another piece of evidence comes from the study of timing in the frequency domain, namely the directed and effective brain connectivity at the sources in subjects with dysphonetic dyslexia and with non-specific reading retardation. The connectivity studies present in the literature are based on measures of functional connectivity, such as coherence, which do not allow to infer effective connectivity. The hypothesis is that timing defect or dyschronia should be reflected also in the effective connectivity, and the subjects with developmental dyslexia have a different pattern of information flow compared to the group of children with a non-specific reading delay. For this purpose, the isolated effective coherence between data-driven selected regions is used as a tool to quantify directed connectivity. The hypothesis is that the timing defect or dyschronia should be reflected also in the effective connectivity. The reason for studying these two groups of children is based on fact that no specific reading delay has not received special attention neither by clinicians nor by researchers. Frequently, these children remain undiagnosed or confounded with dysphonetic dyslexics until they are in secondary school. The subsample consisted of 169 dysphonetic dyslexia and 36 non-specific reading delay with their EEG recordings. This slide shows the isolated effective coherence between dysphonetic dyslexia and the non-specific reading delay. Arrows in red color indicate that isolated coherence information flow between two areas is higher in the dysphonetic dyslexia group than in the non-specific reading delay group. Arrows in blue color indicate that the information flow between the two areas is higher in the NSRD group than in the DD group. In each line, there are annotated the frequency band in which the difference were more significant. This slide shows the significant differences in functional connectivity between the phonetic dyslexia and NSRD groups, summarized by bands obtained by the isolated effective coherence procedure for P minus 0.01 corrected by permutations. Negative values, the blue colors, mean that the connectivity marked by the arrow is greater in the non-specific reading delay group. Positive values, red and the yellow palette, on the contrary, mean that the connectivity is greater in the dysphonetic dyslexic group. Note that the arrows indicate the direction of the causal influence. Most of the blue arrows appear in the beta 2 and gamma band, which may indicate that the left Rolandic operculum behaves as a hub, sending more information to a big number of structures in the NSRD group. The left calcarine sulcus is very active in the dysphonetic dyslexic group, sending information to parietal and temporal areas bilaterally in the delta, theta, and alpha band. Our causality results show a more active connectivity in this phonetic group from the left calcarine sulcus and the right lingual gyrus, which are a part of the usual system, to other regions of the brain. It's interesting to note that the significant differences associated to connections flowing from the left calcarine occur in almost frequency bands, but very importantly, in the delta band to the right post-central, the right supplementary motor area, and the left paracentral lobule. These are almost the only connections that occur in the delta band. We hypothesize that the delta band may be associated to less efficient dysfunctional or even pathological connections. The only connection coming out from the left calcarine which does not implicate delta band is towards the right angular gyrus, which occur in the theta and alpha band. The angular gyrus, together with the right supramarginal gyrus, forms a complex that receives somatosensory, visual, and auditory inputs from the brain. It is considered that they work together to link the words with their meaning as a neural mediator of words and other meaningful symbols accessed through the visual system. It has been shown that the angular gyrus is active during numerous verbal tasks, less active in dyslexics during rhyme detection, and more active in dyslexics during orthographic identification. In the non-specific reading delay group, the left Rolandic operculum is much active than in the dysphonetic dyslexic group. It is important to note that all connections coming out from the Rolandic operculum occur in the beta and gamma band. Improvements in the beta band at the posterior site have been found in a group of dyslexic children after receiving phonological training for 6 months. The increased connectivity from left Rolandic operculum to right angular gyrus, superior and inferior parietal gyrus, right postcentral gyrus, and the right fusiform gyrus in the beta and gamma band may explain why the non-specific reading delay group is more efficient than the dyslexic in the reading process, since those structures play important roles during the execution of reading tasks. We may affirm that this study represents the first attempt to demonstrate which type of EEG connectivity exists in dyslexic subjects using the classification in subtypes proposed by Boder's model. In conclusion, we can hypothesize that at the basis of dyslexia, there is a neural timing defect that causes a disorder of programming and integrating idiokinetic elements associated with a deficiency in the fast processing and integration of sensory information. All these phenomena occur at different levels of the central nervous system at different times during reading. Thank you for your attention.